Anthony, how good was this podcast with Jo Milios?
It was amazing. Like, who would have thought that would be talking about bent penises for over an hour?
Yeah, and I know we learned that. We learned some of it from Jo last time when our podcast kind of did not work,
Did not.
sadly. Uh, but I was amazed to learn that it's just so much more prevalent than I'd ever expected. Like, 1 in 10 men in the general population have Peyroneus disease, which is a crooked penis.
1 in 6 if you have a radical prostatectomy. You know, that was just crazy. But it was really cool to hear about some of the things that we as healthcare providers and even just asking questions about things is easy to do. And I really loved how Jo said that those of us who are physios might have something in the cupboard that might be able to help these people, and it's evidence based. I thought that was really cool.
It was fantastic. So stay tuned, listen to this amazing podcast with Dr. Jo Milios from Perth in Western Australia, and make sure that you share it with your friends and leave some comments in the discussion and let us know what you think.
It's coming up right after the usual announcement.
Welcome to the Women's Health Podcast. I'm Marika Hart from Hemisphere.
And I'm Anthony Lowe, the Physiodetective. Together we interview leading authorities, answer questions, and share our thoughts to provide the general public with the best quality information we can find on all aspects of women's health. Please remember the materials and content on this podcast are intended as general information and for entertainment purposes only.
They are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now it's time to get cracking with the episode. So whether you're out walking your dog, driving the kids to school, or just sitting back enjoying a glass of wine, we hope you enjoy the show.
Hey everybody, welcome back to the podcast. I'm Anthony Lowe, the Physiodetective, and it's my pleasure to introduce to you who's on this podcast today. Of course, it is the lovely co-host, the wiser, smarter, everything better, Marika Hart. Always love doing the podcast with you, and I know that it has been a little bit of time, but it's been a really full time, and I'm looking forward to diving in with our guest today. How have you been, Marika? And I'll let you introduce Jo.
Yeah, a bit like you, Anthony, pretty flat out in the last month, and a bit up and down, to be honest. Life has been kind of kicking me in the arse a bit. Hence, we haven't done a podcast for probably about 4 to 6 weeks. It's been a little while, but lots of exciting things on the horizon, which we can talk about on another day. But good things coming ahead. Look, today we are incredibly blessed to have Dr. Jo Milios. I keep forgetting to add your title in there, Jo.
Me too. Don't worry, it's all good.
Now, we actually had Jo on the podcast last year. We picked her brain for about an hour and a half. It was incredible. And then afterwards, when Anthony went to upload all the audio, 8 minutes was on there. So there was some bug in our Zoom thing, and it was the most mortifying message I've ever had to send to the wonderful Jo to say, you're not going to believe this, but the whole freaking thing has basically not been saved. And so thank you for not writing us off completely as being awful and unprofessional, Jo. We're so lucky to have you back on with more and more of your precious time. So thank you for coming back.
It's a complete honour. And look, IT is interesting. We've all had to realise that we're physiotherapists, not IT experts. And so the teething issues we're all experiencing is quite okay. So I'm just delighted that you have me back. So thanks to both of you.
And to be fair to Anthony, it was completely not his fault. It was some glitch with Zoom. So I can't even blame you, buddy. Now, Dr. Jo Milios is a physiotherapist based in Perth, Western Australia. So I'm really lucky I can catch up and have coffee and ice cream with her from time to time and pick her brains. She works predominantly in the field of men's health, men's pelvic health. And she has recently finished her PhD, where she had several projects, which we're gonna ask her all about. We've asked Jo to come on the podcast again because this is Prostate Cancer Month. And even though Anthony and I this is the Women's Health podcast, and we've predominantly been talking about topics related to women's health, we really wanted Jo to come on and talk about men's pelvic health, because we also, we think this is such an important, it's a huge topic we could talk about for days, but it's something that she has so much expertise in. And we all have brothers, fathers, friends who are male who, we just want to make sure that this information is available out there and people know of Dr. Jo and her podcast so they can learn more. But before we go into sort of the question stuff, Jo, do you want to tell us a little bit about what you do and what you have been doing over the last, 8 years?
Yeah, well, thanks so much for that introduction. So I'll spin back a little bit. So I started off life wanting to be a classical ballerina, and unfortunately, as you may have seen if you've done any presentations, I do have quite a nasty scoliosis. So I'm just going to put it up on the screen there. You might be able to see my 53-degree thoracic spinal curve. Well, I didn't end up being able to have that ballet career, so physiotherapy seemed like a really nice thing to do. I pirouetted it a different way. Physiotherapy was something that was a little challenging for me. Scientifically, the statistics, I think I got 51% in my final exams, but the creative aspect of physiotherapy has really come to the fore with me now in the men's health space, and that all started really through a phone call actually just from my brother, who's a urologist in Western Australia. That was 2005. Speed dial to 2020. I was really encouraged by local urologists in Western Australia to put a lot of the clinical work I was observing into something more formal. In 2012, I commenced a higher degree by research at the University of Western Australia. Purely and simply, I wanted to investigate exercise and pelvic floor and think about developing a program for men with prostate cancer to implement that into the community to improve the everyday quality of life of men, particularly focusing on whole body exercise training as well as pelvic floor, but particularly the sexual function. I found that the continence aspect of men, particularly with prostate cancer, was being very well addressed in the women's health field, but that sexual dysfunction was not being talked about, not even with the urologists. And long term, through my own sort of preparation by bringing in a lengthy prehabilitation time between diagnosis and surgery for the prostate cancer patients I was working with, that we found it was really quite easy in most cases to regain continence, but then the sexual dysfunction was a major issue. So my PhD focused on, I've got my PhD here. I'll read the title: therapeutic interventions for patients with prostate cancer undergoing radical prostatectomy, a focus on urinary incontinence, erectile dysfunction, and Peyroneus disease. I'll also let you know that halfway through my PhD, so I was working full-time and doing this part-time, and in about 2015, I had a bit of a crash of confidence after going to a few conferences and getting quite a lot of sort of tardy responses, and I thought, oh, I'm going to put this PhD away. And I decided just to go and pursue a bit of creativity and became a yoga teacher, because that always helped me for my spine. And I've actually found that's been the greatest asset to my PhD, because now I have a much better understanding of whole body health and the relaxation components for myself as well. So I only put that PhD aside for 2 months, but picked it up again. So in total, it was 7 years of part-time study. And I just used to say it was my hobby. So I just plug away while my family are watching the Frio Dockers. And yeah, I think that's a long enough introduction. Finally graduated just in December 2019.
Congratulations, Jo. So much there to love. And of course, the one thing that really irked me was right at the end, go the Sydney Swans forever. I know Marika's a Freo fan as well.
Oh, Marika, can I just put a plug to Fiona Rogers, because she bought me this cup that I'm wearing when she came to Rottnest for a day last year to Perth. We had a day at Rottnest together, and she bought me this cup at the Rottnest ferry stand, and she goes to the Brisbane Lions, so it's a bit of banter there. So
that's okay. And at least you're not a West Coast fan, so I suppose there's always that grace.
I have to pretend a lot though.
Well, so do I, Joe. You know where I work.
Oh, you do? I actually rang you the other day. I was trying to get to the doctors to tell them about the Shockwave machine I've got, and I accidentally rang you guys, and I put up the phone. I was like, I want the machine at the doctor's. Anyway.
Wrong place.
Sorry, I called the wrong club.
Good, all good. All right. So once we got the football out of the way, so, it's really interesting that you talk about, the fact that your brother's a urologist and, the role that physio can play, the sexual dysfunction, the incontinence, as well as the Peyroneus Disease. Do you want to briefly touch on what Peyroneus Disease is and why is this important, please?
Sure. Well, Peroneus Disease is a curvature or deformity of the penis, and I certainly didn't ever anticipate to investigate that in my PhD, but I came about knowing about it because one of my patients, who was a much younger patient, he was 45 years of age when in 2014 he underwent a radical robotic prostatectomy. So he had a complete recovery of his cancer, his continence within about 4 weeks. And when I discharged him at 6 months, because I like to just make sure that between 3 and 6 months, they don't go into a psychological dip. So even if they're continent at 3 months, I say, I'll check in with you at 6 months. Because if they haven't got their sexual function going, a lot of men really start to drop their bundle a bit away from that sort of early intensive time. So this chap came to see me at 6 months, 3 months between visits. He was doing really well. He had a spontaneous erectile blood flow emerging, and I was pretty happy with that. And anyway, I got a knock at the door of my physio clinic about 6 months after that. He was very distressed and asked if I could chat to him for a minute. I brought him straight in because I saw he was really struggling there. And he produced a photo of a very bent and curved penis that was deviated 75 degrees upward to the left. And he said he felt a hard lump that was painful, and he was petrified that his prostate cancer had returned into his penis. I quickly reassured him that it was likely not to be cancer because I was aware of Peyroneus disease. Startlingly, I made the observation that 1 in 6 men who undergo a radical prostatectomy will experience Peyroneus disease if we don't do something called penile rehabilitation. Penile rehabilitation is what I was talking about earlier. It means getting men to work on their sexual function recovery from day dot, which includes pelvic floor exercises, as I was able to show in my own research built on the work of Professor Grace Story. We know that Peyroneus disease can occur in 1 in 10 men away from prostate cancer treatment. We know that there are many reasons. There can be, I've got 3 young patients at the moment who have experienced a coital fracture. So they've been having sex with their girlfriends. One of them is 17, one of them is 19, and one of them is 31. They're the typical sort of patients. They come in very distressed, bruising, pain in their penis, deviation, unable to have sex. One man said to me, "What use am I as a man with a broken weapon?" Penile function, penile length impact greatly on a man's masculinity, and this is something that I felt needed to be discussed. It became the 1/3 unexpected chapter of part of my PhD with a random controlled trial utilising therapeutic ultrasound, and we can talk more about that. But Peyroneus disease doesn't just mean bend, it means any change to penile function, and it can occur at any age group. My youngest patient's been 15 and my oldest has been 85. So I think it's a really important topic. One of the main reasons I've set up my own podcast recently called the Penis Project and all things P in men's health, because it's the depression and anxiety that comes as a sequelae when young people don't have sexual function. Older men tend to cope a bit better, but I've got even one patient who's never married, never fathered, and he's 54 from a coital fracture at 21. So we're talking about whole lifetime impacts here. It's important to chat about.
Yeah, absolutely, Joe. I can imagine that would affect quality of life to a huge degree. We're going to come back to the treatment side of things, because I think that'll be fantastic for you to cover, because it sounds like as traditionally there. No, I'll come back to that. I'll come back to that. I just wanted to ask if you wouldn't mind just quickly going through why people after a radical prostatectomy have difficulties with incontinence and sexual function. If you just quickly can talk a little bit
Sure.
about some anatomical changes, that would be great.
So I like to let, first of all, guys know, well, I always do a number of ways. Just the other day, I had a blind patient and his blind wife. So I had no tools whatsoever, no screens, no ultrasounds, nothing to show him visually. It was just talk and touch. So what men need to first of all know is they do have a pelvic floor. Most of them anticipate when they get told to go and see a physio, they're going to get on the floor and do a few push-ups and maybe some sit-ups and things, and that's their floor exercises. So it's important to understand that the pelvic floor is a essential piece of male anatomy as well as female. It's in the same body part in the perineal area between the coccyx at the back and the pubic bone at the front, and it's a three-layered hammock basically that controls our bowel, bladder and sexual function, or has a role in it. And then we have the prostate, which sits just beneath the bladder, which has its own sphincter, which is called the internal bladder neck sphincter. And the bladder and the prostate automatically work together to help control storage and elimination of urine. So when a man has prostate cancer and needs to have it removed, then he's going to lose his autonomic bladder control support mechanism. The problem is that the pelvic floor for a man is unaccustomed to the load that it's going to require, because it loses the support is about 4/5 of what is required gone. So you have the prostate embedded at the base of the bladder, that's then removed. The base of the bladder in the sphincter is stitched into the internal urethral sphincter. That then has to survive, copes really well when guys are supine or sitting still, but once they get upright and start moving, it's a whole different ball game. And what we know is if we do pelvic floor exercises in standing right from day dot, I do all my assessments and training programs, as I was able to show in my PhD, in standing from the outset, to get men training with load into maximum physiological requirement based on male anatomy and male and pelvic floor physiology. Another reason I worked with exercise physiologists to do my PhD in the first place, because it was just information that we didn't have a lot of in physiotherapy schools, in my experience. What is good to know though is if you activate the pelvic floor for your urinary function, you're also activating it for erectile function. So I tell my patients it's a 2-for-1 bonus. As soon as you tell a bloke that he's going to lose his penile length as a result of surgery because of the lack of blood flow, so the nerves that wrap around the prostate are responsible for a male innervation of that blood flow, so his penis won't grow, won't lengthen, and that will impact on the girth as well as the length. And well, look, put it this way, penile length is the most looked up internet topic of all search engine topics. So we know it's on guys' minds, but we know that there can be a spiral of somewhat challenging websites and information sources. So we want guys to know, A, they have a pelvic floor, that it's a simple approach of just squeezing the front passage, drawing up their testes, drawing their penis in, or as I say, lifting their nuts to their guts to get that opportunity to work on urinary, sexual and also bowel function. It's a no-brainer. They just need to know they have one.
Right. So you just dropped a whole ton of knowledge there. So lots of different things that I just heard you say. Things like the interesting thing was the 4/5 of the support was gone after a radical prostatectomy. So the support from the prostate actually being there in the base of the bladder provides a lot of support, and that's taken away. And then, the blood flow issues, the nerve issues. And then, you started talking about penile length and girth. And I wanted to make a joke, like when you there's you said it in a very polite way about information on the internet, and I was going to unmute and say, so do you mean porn sites are not indicative of normal penile length and girth? But
well, Yeah.
That is a lot of what guys are judging things off.
Anthony, it's such a good question, because we have a colleague in the UK, Jared Green, and a number of others, Carl Monaghan and Bill Taylor and Adrian Wagstaff and a few others. They're all really aware of something called hard flaccid syndrome, which is occurring in young men between about 18 and 35. It's a lot linked to watching pornography, particularly in COVID times. People are spending a lot more time at home, and they're doing something called jelqing. They're actually vigorously stimulating them so much that we're getting penile injuries. This can lead to Peroneus Disease. But hard flaccid syndrome, which is like the female equivalent potentially of persistent genital arousal disorder, where we've got this constant sort of blood flow arousal that is not normalizing because they've got hypertonicity in their pelvic floor, or they've got a hypersensitivity from injury. So again, that's a quality of depression, anxiety, and not knowing what to do and where to go to get help. So yeah, it's penile length. There's search for perfection. Unbelievably, there's something called small penis anxiety. So when I've done research on men who believe they have this, their partners have been interviewed, and 85% of the time say they have not a problem with their partner's penile length, and yet men have this true psychological disorder arising from their fears around it. So it's pretty hard in an Instagram-y, Snapchat, social media presence for young people to know what's normal.
Yeah.
And it's one of the things that, oh, sorry, Anthony, were you going to say something? I was just thinking about the penile length, Jo, because I've started working with men over the last year post prostatectomy, which I have to say I've really enjoyed.
Yeah.
Just love working with the blokes. But with the penile rehab, what I found sometimes is that because of the cancer is a big deal, right?
Yeah.
The cancer is massive. So in that process, when they're processing all of this information, dealing with the incontinence, because often when they come out, they're literally just like a tap running, right?
Yep.
For that first period of time. And then that improves at night time, and then it gets better in the morning, and then they often go through the process.
Just building up endurance in the muscles.
Yeah. But when I asked them about their penile rehab, because they often see your colleague, Melissa, who we will definitely talk about in a minute. Sometimes what I'm finding is that they'll just say to me, oh, look, I'm not interested in sex. It's just not on my radar right now. And then I'm having to sort of, and I'm sure it was explained to them earlier on, but explain to them it's not just about wanting to have sex right now, but we want to actually maintain that blood flow, maintain that length. And then when you start talking about length, then it's like, oh, shit, I better start getting onto this, because that's a real fear.
Yeah, I'm so glad that you've noticed that. And first of all, I want to say men are just the most wonderful in this cohort patients I've ever worked with, because they're so motivated. They've got cancer, which freaks them out. Usually they're asymptomatic when they get diagnosed. It's just a blood test that's gone a bit awry. So they get told, yep, go along, have your surgery, but you're going to be cleared of cancer, but you're going to be impotent and incontinent. And literally, and I don't mean to be rude at all, Anthony, but just about every guy says to me, I can only deal with one thing at a time. And when I heard that word cancer in the waiting room or from my doctor, I didn't hear anything else. So they're fixated initially on, I've got cancer, and then I want to have 24-hour bladder control, because men are not used to losing control of their bodily fluids. So those two quality of life things, in fact, the survivorship, number one, we always say is important to rank. Prostate cancer clearance, continence, and then sexual function is going to take a lot longer. Even the best studies that we have from a guy called Nelson and his 2013 study, Chris Nelson, showed that only 22% of men will regain their sexual function at 2 years post prostatectomy. So that was my motivation for my studies into this body part as well. So you'll find, yep, men will want to go cancer, their education, they can deal with that. And then I actually say from day dot, I'm going to be asking you about your sexual function, and any consult hereafter, please feel free to answer a question. Ask a question, should I say. I say there's two physical side effects from this surgery, and I'm a physical therapist, and I want to acknowledge both. They're long-term, your getting back to quality of life and being you, your normal you, needs to also address the masculinity side of it. But then I also make sure that we're talking about function versus sex. And once you start talking about function, normal appearance, normal length, it takes a lot of pressure, that performance anxiety and reluctance to embarrass themselves in front of their partners or even have to confront it away. And that's why I do the continuing observation of men, because even if they're continent, down the track, if they've missed their window in the first 6 months to work on their sexual function, they've got penile atrophy, potentially Peyroneus disease, and then it's a whole different story. And so, we've got a friend, my dog Apollo's just decided to come sit with me. I was wondering if you could hear him crunching that in the background. So I'll move him away in a second. We do want to have an open and respectful conversation, but we don't want to put pressure on guys that it's about sex. It's going to take a couple of years mostly to get their nerve recovery. We say if you don't use it, you'll lose it. And my whole desire for doing that Peyronie's extra random control trial was to educate, and minimize guys going through what my younger patient Phil went through. Who's the inspiration. I'll also add that 6 years later from the ultrasound therapy, he's perfectly fine, and he has about a 10-degree lingering curve. We just did a Shockwave one on him the other day, and he reported back that it was completely incredible, and I can't wait to share more of that.
It's great news. And, you know, some of the best research ideas come from our interactions with the people who see us. So it's great to hear how that inspiration and the research and, you know, 22% regaining their sexual function by 2 years, all of these things. And it's interesting that you mentioned, you know, cancer being the big thing, and then after that not being able to hear anything else, like that's a common story no matter who you are and what type of cancer that is. It's difficult to hear everything else after that. But what I find interesting is that there is so much of a focus after the operation, after the prostatectomy, of, okay, you know, you're basically leaking like a tap that's been left on at the moment, and there's that focus to incontinence and the pelvic floor work, and there definitely doesn't seem to be as much of a focus on the sexual function, particularly if it takes a couple of years for it to come back. So that's definitely.
So this is the thing. Like, that's when the coin dropped for me when I saw that slide at a prostate cancer conference in 2014. I knew that this was being under addressed, but I didn't know the stats were that bad. And if you actually break it down, for anyone over 60, if they don't do penile rehabilitation, they've got a 4% chance of getting their function back at 2 years, if they're over 60. Now, the average man in Australia and probably globally is about 62, 63. And older people do have sex still, and it's a really important part of their masculinity, as I said earlier. For me, it was a driver. I've come to realize probably that man to man talking across a table about penile function, as in a urology office, is not a pleasant or comfortable conversation for both men in the room. I actually, over my 15 years, have had 3 urologists write letters to me, formally requesting me not to discuss penile function with their patients. And I've said, well, I'm very happy to do that if you're happy to discuss it. One surgeon didn't refer me patients for 6 years because of that particular response that I gave him. The other 2 were fine. Said, please go for it. We understand that you're helping. And now that surgeon, you know, now that my work's published, he's come back and started referring again. So it's an uncomfortable topic. Peter Dornan taught me many years ago as my men's health mentor that pudendal nerve is the nerve of the private parts, and S234 travels on the inside of the body. We don't really have very good MRI imaging, even knowledge to be able to see it. But men aren't going to talk about their private parts public, and certainly not amongst their mates when it comes to something serious. There'll be a bit of banter and humour, but at the end of the day, it's just not going to be a topic they want to talk about across the table to one another.
Absolutely. And, it is a difficult topic, like you said. What's really interesting about what you said was that even the surgeons, like I'm surprised, I'm still sitting here surprised that a surgeon was upset that you were discussing this with people and upset with your response. Okay, you talk to them about it. Like,
that's only because they were asking me the questions as well, Anthony. Like,
of course.
they'd say, now you've fixed up my continence, what can we do about my sexual function? And I'd say, oh, this goes back to 2005. What's your surgeon discussing? Oh no, that hasn't been mentioned. I'm so glad things have improved a lot in this time. But if we think about it, Australia is actually a long, long, long way ahead here. We have had the first men's health courses with Pauline Chiarelli. We have had people like Craig Ellingham and Peter Dornan talking about it, being active in prostate cancer forums and community workshops for 20 plus years. We've got a voice from men in Australia in the field. We've actually probably not globally got that going so much because pelvic health has predominantly been a female area. And even myself, I was being very challenged because I didn't do women's health training here at Curtin University as a postgrad, but that's because at the time there was neither a course nor any men's health content anyway. So from a musculoskeletal background, I literally just followed my brother around and learned from the patients. And then I would get referrals from him that say, basically, Joe, I don't know what's going on. I can't find anything. We've done STD checks. This man's got pain. We've given him antibiotics. He's got prostatitis, but only 3% of guys get better if they have prostatitis with antibiotics. And it turned out to be the opposite of what I was doing for the prostate cancer patients that needed strengthening. This body of patients needed relaxation and movement of their pelvic floor, by which time it had escalated to, a range of musculoskeletal, whole body pain, anxiety, depression, bowel, bladder, sexual function. The education space has been so lacking for men. And the familiar thing to me, or the reassuring thing to me, is it's a familiar story. So no matter what country I've had the opportunity to teach in the last 5 or 6 years, there's the same statistics. Men live 5 years on average less than women. Men lead in all the adverse health conditions, including things like suicide. 80% of all suicides are performed by men, and that's 1 man per minute globally. Men not so good at preventative health or asking for help. They're reluctant. And there's lots of cultural reasons for that, but I'm really inspired by younger patients. That the most recent patient with Peyroneus Disease, who was 19, came with his mother to the appointment, and I was really taken aback. And I said, oh, lovely to meet you both. It was 6:30 on a Saturday morning. What would you like to do? Would you both like to come in? And the young guy said, yep, I want my mum there because she's helped me get to this point. She walks in and she said, my son's we know he's got Peroneus Disease. We've been sent to you from the GP who's aware of your research. I'm just worried about his headspace, and I'm going to just have a chat here and then I'll leave the room while you examine him. And I'm doing it now again. I actually was so overwhelmed because here we're changing things. We're getting younger men talking to their mum and sharing this. And this is where education, I feel really hopeful that we're going to reduce a lot of these chronic disorders if we can. It's really motivating.
I think that's something that I was chatting to some friends about the other day. I know what we're talking about. We were talking about concussions, and I said, is there much of a difference between men and women in terms of, outcomes, etc., and how they present? And there were some little things, but this physio that I work with was telling me that because women tend to present to their GP with issues far more often, that's why, excuse me, they do tend to get diagnosed more, they do tend to get more follow-up care, etc. Because a lot of guys, when they have an injury, will kind of toughen it, toughen up, push on, not tell anyone, and not seek help as much as women do tend to do. Jo, while we're talking about Peroneus, because I wanted to come back to the treatment side of things. So I remember in that amazing podcast that we did that totally vanished.
Got lost in cyberspace. It's going to appear one day. I'm sure it will. Karma's going to come back.
I don't know. You talked to us about that. So when you started off your PhD, you were going down one track, and then this Peyronie's disease.
Bend in the road that I had, yes.
The bend in the road, exactly.
Yep.
And I remember you were saying that at the time you thought, shit, what do I do? What do I do here? I want to help this kid, but I don't know what tools I have. And that I think you spoke to Sandy Hilton, is that right?
Yes, I did.
Then obscure little things in the literature, but there wasn't much information out there. Do you want to share that little story again about how?
Sure. So this guy presents to me in November of 2014, and my husband's Greek, and he's also a physio dean, and we were going to visit his Greek family in Chicago. And because of the Facebook groups that we have, the women's health groups and the men's health one that I set up a few years ago, I had awareness that there was two physios who were very interactive, Sandy Hilton and Sarah Haag. And just through Facebook Messenger, as we've done even today between us, connected with Sandy to go out for dinner and Sarah. So they took me out for dinner, went to a saloon, had, ribs, I think, and barbecue ribs, like a massive meal, as you do. And I said, hey guys, great to meet you, blah, 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 blah. We talked about everything. And I said, look, I've just come across this one case that's really intrigued me. Have you guys ever heard of Peroneus disease in the physio clinic? And Sandy was like, actually, I used to work in the Defence Forces, and way back in 20 years ago, we had 3 or 4 young guys come in with injuries, and we just provide everyday therapeutic ultrasound, and very quickly they resolve their pain, their swelling, bruising to the area from physical trauma, but also we were able to greatly improve or minimise the impact of the curvature. She said, we just devised this little thing where we would do 5 days a week ultrasound, which was then backed up by 3 weeks of, 5 days in week 1, 5 days in a row. Week 2 was 3 days, every second day. Week 2 was 2 sessions, and then the final week was 1. So there was 11 sessions over a month. So he said it looked pretty good, but it was just, anecdotal. We didn't really do much with that. And I got me thinking, so because I was a little bit familiar with looking into all the, academic papers with a bit more skill, I uncovered that there was a paper in 1983 by Dr. Miller, a urologist who's done a clinical case study series where he'd actually used therapeutic ultrasound, and he had a collection of 26 patients, and 19 of them reported improvement. So reduction of curve, reduction of the lump, reduction of pain, and re-engagement in sexual activity. So pretty positive. Fortunately, because I got access to his paper, I could see that there was another 3 papers that he'd drawn a body of work from. But I couldn't get those ones because they were from 1951, 1967, and 1971. And then through UWA, the librarian's very helpful. They tracked them all down. And then I had this body of work spanning about, I haven't actually added them up, but we'd say 1,000, maybe 1,200 case study series that had shown about 70% improvement across the board with all of those parameters. But 2015, a lot obviously later, from 1983, 32 years I think, well, nothing had been done. And why? I don't know, technology, different medications. I'm sure people reckon it is a very confounding condition to treat. So they can do injections into the area called collagenase injections, a whole range of things, but there's only about a 30% benefit across all of these things, and even surgery to fix it can be done. But the general rule is let's wait and see, because there's an acute phase of this condition and it takes 18 months to stabilize. This Peroneus disease will occur in what they call aberrant wound healing in genetically susceptible individuals. So a lot of these guys have something called Dupuytren's contracture, which is in the 4th and 5th digit. You'll probably be aware of those tendon, like curling of the fingers. Something called Lederhosen's, which is a little lump fibromatosis in the plantar fascia, and a whole range of other things. But there is a genetic link. And so we really wanted to just identify how we could treat it. I pretty much fumbled my way through all those papers, worked out a protocol loosely based on Sandy's. I just decided to do 3 sessions a week for 12 weeks. By this time we had a penile Doppler scan imaging available. Our first patient's name was Phil. He doesn't mind sharing his story at all. We scanned him, found some plaque. I proceeded to do the 12 ultrasounds using continuous ultrasound on a 3 megahertz dose, high intensity, 2 watts per centimetre squared. We did that for 10 minutes, 3 times a week. For 4 weeks, we rescanned him and there was complete resolution of his Peyronie's plaque. And there was this mini foci calcifications that also were completely resolved. The sonographer and radiographer called me in and said, Jo, we've never seen this before in 25 years of scanning. What have you done? You're onto something. We're going to send every man with Peroneus Disease your way. Currently, patients are told to wait and see. 88% of the time I uncovered these conditions either get worse or stabilise. We know more than 50% of men with Peroneus Disease have clinical depression. And here we go again. Then went back to my supervisors. They actually said, Jo, we're not real keen on looking at penises, because guess what? They were 2 guys, Professor Danny Green and Tim Ackland. They didn't want to have this discussion. So they said, nick off and go and do these 3 or 4 more cases and come back to us if you find any consistent thing. Because one case study ain't going to cut it, Jo. So they're pretty tough on me, but I'm glad they were, because I got the same results. And then we did the random control trial, and it only got published on the 8th of the 8th, 2020, finally. Peroneus Disease and the role of therapeutic ultrasound, a randomized controlled trial on the Journal of Rehabilitation Therapy. 6 years of work, that one.
That's so awesome, Jo. The the journey to getting stuff like that out, and the video was not on my face at the time, but like I don't know if you saw, but my eyes widened and I was a bit surprised at such a high therapeutic ultrasound dose. You know, like I tend to get burning sensations anything above 0.5 watts per centimeter squared. So
yeah, it has to be very individualized. And the thing with the random control trial is, I was basing this on the body of your work from those urologists. So I initially started off with 1 megahertz, but that was too painful. So it shifted to 3 megahertz. But 70% of men, and also in my trial, in the results, improved on all those parameters. And I recently just did a presentation just last week, actually, for a company who've got a focal shockwave therapy machine, because they approached me at the end of my presentation at the Australian Physiotherapy Transform course in October last year to say, Jo, those 30% of patients that aren't getting better, why is that? And I said, because they've got calcification. Ultrasound is not going to penetrate that. It's going to be painful. But what it does is it helps reduce the likelihood of that chronicity, the plaques getting bigger. We treat it like a soft tissue injury acutely, and you know, individual personalized, yes, we do have to address this, but alternatively, the shockwave, the focal shockwave, is far more painful. So I find a combination now of 3 or 4 ultrasound sessions to decrease that initial inflammatory process. Also encourages the guys to feel more comfortable with that very personal and private application of the ultrasound. But it's very well tolerated, and a bit like mastitis. I spoke to Professor Peter Hamer when I first started talking about this, and he said, Jo, ultrasound works really well. Every physio's got one in their cupboard. It's just that it's very specific. You know, if you get the right condition and the right parameters, there's no reason why it can't actually have a role, for sure. Because I said, you know, ultrasound's got so much flack in recent years, and he was like, yeah, but we use it in mastitis. And he was the head of Notre Dame at the time, and I'm really quite grateful for that one conversation, actually, because yeah, you know, trying to convince people that ultrasound had a role has been challenging, but I'm really delighted with the shockwave. Actually, I think we've got potential to have a huge role across the world globally, in starting off the ultrasound, but potentially having a specific kill working with urologists, providing the shockwave, because it is a bit time consuming. That's a 20-minute treatment, and urologists are probably not going to want to stand there and do that. And Apollo, sorry, my dog's barking. Sorry, come. Keeping it real here, everyone.
No, that's okay. I was going to...
Okay, I lost my train of thought.
That's okay. I'll give you another train to jump aboard. You know, like, it's almost like science, right? Like, I know that therapeutic ultrasound, for a lot of the things that we thought were helpful, wasn't helpful for the reasons that we thought, but we all have memories of, you know, seeing people who responded miraculously to it.
Yeah.
And it's almost like, hey, there's still a role for therapeutic ultrasound. We've just got to more clearly define what is suitable and not suitable.
Yeah.
You know, you spoke about mastitis, and you've spoken about Peyroneus disease. You spoke about the calcification. Is there any way of preventing the calcification? Is it the wait and see approach that's leading to calcification?
Absolutely. So currently, if you get diagnosed with Peyroneus disease, you'll be told from your GP, come back in 6 months, but there's nothing we can do. There are medications, but they don't work better than placebo. You can have penile injections. They're going to cost you about $1,200 each, but you need 6 to 10 of them, and they're not on the PBS list anymore because they don't work or they cause more bruising. You can have surgery, but you've got to wait 2 years, because if we do surgery too soon, then you can cause even more scarring in genetically susceptible individuals. And my brother, who actually I didn't even realise specialises in corrective surgery for this as well, I only found out he specialised in it halfway through my own research on it, because I opened up a urology journal and he was discussing it. So we have a nice pathway. I've watched him do a couple of surgeries now, and the surgery is very effective, but we don't want patients to get to that point if possible, because he's even said, I've learnt the hard way of jumping in too soon, because these patients are usually very paranoid and distressed and want it fixed now. And the problem is, if you have this calcification, and I believe that the ultrasound can minimise this, because I've actually not had anyone get worse while I've been doing the treatment. Apart from one patient actually who had small cell lung carcinoma and was on heavy drugs that were affecting his kidney and a whole cleansing actually. But everyone else is either stabilised, got better, and even in those guys who had the calcification that didn't respond to ultrasound, all of them had pain reduction usually within 3 sessions, and all of them had a dexterity and improvement in the softer tissues. So the goal is, let's use physiotherapy ultrasound that every physio has is covered globally if we get the chance. We don't want patients to have to wait 2 years. If they have surgery because it's calcification beyond that time, they're going to get penile length reduction. There's going to be affectations to the dorsal penile nerve. That's going to impact on erectile function anyway. And even surgeons are reluctant to do this, and they'll say wait and see for up to 2 years. No man wants to wait and see and feel their penis shrinking, bending, getting worse. Then they end up like that patient of mine who's never fathered or married or he's a virgin still.
So Jo, just coming back, you said early on, in terms of the statistics with this, it was about 1 in 6 for men who've
After radical prostatectomy.
And 1 in
This
10.
is all evidence-based. Yep.
We're talking huge numbers then. If we're talking 1 in 10 general population.
And this is the most interesting thing is there's only 30% roughly known history in any of these guys.
Known history as some kind of injury or surgery or something trigger. Okay.
There's a massive undisclosed, unfounded population, and I believe it's pelvic floor hypertonicity. Based on my favourite paper of all times is by a lady called Debbie Cohen. She wrote it in 2016, and it's the role of pelvic floor muscles in male sexual dysfunction. And she talks about the internal pudendal arteries being compressed in pelvic floor hypertonicity, which then compresses on penile blood flow, which then over time leads to reduced filling of the chambers of the corpus cavernosa, which then leads to this fibrosis effect. And actually, you asked me that question earlier, Marika, and I didn't quite answer it properly. The men who have radical prostatectomies, or even any man with this pelvic floor hypertonicity, they should be getting normal full erections while they're sleeping, called nocturnal erections, 6 to 8 times a night. Now, if they don't get that happening because of nerve injury or compromised blood flow, they will end up with this penile tissue atrophy, apoptosis or cell death, shrinkage, and over time this laying down of deposits, scar tissue, collagen, and inflexible penises that then become rigid. And it's only seen in erection, so you don't see it when men are at resting time. And so if men take 1 to 2 years to get their nerve function back right, they don't even know until it starts waking up and it's bent. And then they're like, now what, you know? Geez, I've been through cancer, I've been through incontinence, and things are working, and now what have I got? That was Phil's story.
So just to jump in on there, the wait and see approach is a problem because it allows a calcification to take hold, which makes everything harder to deal with. No intended. And then you have the inability to tell, like as a patient, that it's there because you only tell during an erection.
Yep.
You have, the nerve supply knocked off in surgery like it usually does. It takes up to 2 years back. So
at least 2 years in many cases,
So is the goal, like, how can you tell before they get nerve function back?
So they start to notice. This is where self-scanning, self-awareness, my yoga comes into it now. We want guys to know what's normal for them. We want them to play with themselves, as boys do anyway, in the shower, maybe once a month, just like girls do with their breast check. Just check, feel their testes, feel their penis, notice if any lumps and bumps. Be aware of any pain or change. Be aware of any minor indentation or changes to erectile function. We also know there's a huge amount of guys with Peyroneus disease who have cardiovascular disorders. So they've got a 3-year window of noticing changes in their penile function or feeling or sensation or shape before they might have a heart attack. We actually lost one of our patients on our trial through having a massive heart attack because of his unknown cardiovascular disease linked to his Peyronie's. So, education, again, boys don't have monthly menstrual cycles, so they don't really know when things change from one month to the next. That's part of the problem why they're probably not so great at picking these things up, because it's slow. It's a slow thing for things to change.
Right. So definitely got to pay attention in the shower, and
I think the first of every month would be something we could get guys doing. Like, why not just talk about it, share it?
Yep.
Yeah.
Yep. Sounds good. I did have a question. So, checking for it. And so you mentioned slight indentations, basically anything that's a little bit different to usual.
Yeah.
And, in the people that you've seen, so we're talking about general population there, but like in the people you've seen after a prostatectomy, they're getting over cancer. They might have had to have chemotherapy, radiotherapy as well, depending on the state, things like that. So noticing these subtle changes are still important and should be part of the conversation that people have. There seems to be a genetic component to it. So they've had Dupuytren's contracture or the Lederhosen, I can't remember effect. I wanted to say Lederhosen effect, but
Lederhosen's. That's quite rare, but I have got one patient with all three: Dupuytren's, Peroneus, and.
I ask about so then if they're prone to developing like tissue hardens and shortens, is that like an indication for surgery then, even that they may have adverse effects from surgery or anything?
You mean for prostate cancer surgery or any surgery?
Any surgery for the Peyroneus disease.
Oh yeah, absolutely. That's why surgeons wait and see. What we want to do is not get them to the chronic calcified stage, which ultrasound actually was able to do. It wasn't, once we got to calcification, the ultrasound didn't work. The Shockwave technology comes about by blasting the calcification. So that's promising, but you've already got complex patients who are depressed and relationship breakdown by the time you get there. So pretty interesting, isn't it?
Sounds like we need someone to also do a sham ultrasound, therapeutic ultrasound trial as well, Jo. Is that going to?
Oh, well, that was my trial. That was my trial.
Oh, you did? Okay.
Yeah. So the thing is that when I did the sham, you give patient consent. So I set it up so that we had a control group receiving sham ultrasound for 12 sessions. So the machine was going to be off. Then we had me providing the intervention over 12 sessions. But once the men started reading the consent forms and realized that they might be directed into sham, they were very reluctant to enter the study because why go through all of this
For weeks and weeks.
Yeah. And, I went back to my supervisors and I said, the guys are super keen to receive the treatment, but they're a bit concerned they'll end up when we randomise them. And they said, well, there's another way we can do this, Jo. We simply do a delayed entry. So we changed it. So we got all of the guys to do everything. So they had Doppler scans, they had something called the Peroneus Disease questionnaire. We had pelvic floor real-time ultrasound function tests that I designed. They weren't allowed to be on any medications. We had quite a broad thing. There was no other thing. They weren't allowed to use a pump or anything whatsoever. The control group started their period of time of 4 weeks without any treatment, and then had all of those tests all over again. And they were compared to the group that received that. And we were able to find clear differences between the two, including the Peroneus disease plaques getting worse in that 4 to 6 week time between the penile Doppler ultrasound. So the difference between the 1983 studies was we had the advance of technology, and we showed true biological data change, which again has been extremely pivotal, which is why I got the paper published, really, because there was nothing from me on that. That was an independent blinded assessor, sonographer and radiologist determining biological data change that they'd never seen before.
Yeah, that is awesome.
I know. I actually think it's probably the most important bit that I did unexpectedly. Yeah, it's so motivating, because when you get that mum and the son come in the other day, and by the way, I've discharged him within 6 weeks. He had 3 ultrasound sessions and 3 shockwaves and back to normal, completely fine. I've never seen that.
That's amazing. Jo, I was going to ask about the penile pump and Cialis and things like that, but I think probably what we might do is direct people to your podcast, because I think you and Melissa will just cover all of that in so much more detail than probably what we have time for today. One of the topics that you mentioned wanting to discuss a little bit more was pelvic pain in men. Because again, this is probably something that blokes don't really want to talk about. So pain in the penis, pain in the testicles, pain in the perineum. I know in Perth, you're talking about that, is it the numcocks, the cycling group?
Oh, numcockitis group. Yeah, I think it's really funny to have a cycling group. When they hop on their bikes and go for a cycle, they've all got a numb cock, and they call themselves numcockitis. And I just think that's not so funny, because it means they're having pudendal nerve compression and potentially erectile dysfunction and potentially Peyroneus disease.
Yes. Hopefully it's more of a support group where they're all going out and getting fantastic management.
All they need to do is get a prostate relief health seat. So that really easy. You just get out a bike seat that's got a bit of a wider brim for the SIJ tibial tuberosities, and have a cut out middle, and then you can cycle your heart away.
Do you want to quickly tell us a little bit about some of the blokes that you see with chronic pelvic pain? And again, I think you've done such a fantastic job of indicating where some of the early management for people could be fantastic from a health professional point of view. But I'm thinking of our listeners. We've got health and fitness professionals. What are some of the things that we should be screening for, looking out for, and how can we best support men early so they don't get to this chronicity?
I think we need to all, I'm going to say, man up and ask that personal question. Do you have any concerns with your bowel, bladder, or sexual function? Yes or no? Have you had anyone screen that then? This could lead to cardiovascular health. So pain in the penis could be because of a tight pelvic floor. It could be because of Peyronie's. If there's noticing any ED, it could be cardiovascular onset. So we need to say, in fact, the International Society of Sexual Medicine just last year for the first time announced and recommended that all health professionals should be screening men for cardiovascular disease by asking about their sexual function. We should all be doing that. For the heart, heart health and heart health are related is one of my phrases. So then we have pain. So if people have tight hamstrings, tight lower backs, they'll often have things like osteitis pubis evolving. But if you come up with an X-ray or scan that shows, there's no mothball appearance there, well, it's an adductor tendinopathy. Could it be that they've actually got a pelvic floor that's a bit tight because they've got L1-2 ilioinguinal nerve compression and genitofemoral compression, which is then also affecting their penile blood flow. Pain, so pain generally is linked up through the work of Peter Donnan to the pudendal nerve dysfunction, and only 3% of the time is the nerve entrapped, which needing surgical repair, but the rest of the time physio is going to really be, you know, the option. Chronic pelvic pain, numbness, tingling, burning, constipation, like a lot of people, guys who have issues with evacuating their bowel, they might start to get hemorrhoids. As you know, Marika, there's quite a lot of relationship there with the tight pelvic floor. So have their habits changed? So there are questions that we should also ask in that: bowel, bladder, sexual, just generally. We don't all have the expertise to know, but at least if we ask the question and flag an abnormality, we can then refer on to, you know, pelvic health therapists or doctors or whatever it might be. Urinary, it just changes. Are you getting up more at night than you were, or any pain or increased frequency? There's just a little window for us to ask a couple more questions.
Yeah, it's so important to have those screening questions, and I found that, well, at least for me, by having them on a form, like an intake form, can often start the process, and even just set the stage, set the tone that, hey, you know, these things are related, or even have a conversation with somebody about why these things are related. Like you said, heart health could be heart health related. So
you just got to demystify it and not make it such a precious, private, you know, taboo topic.
And there's so many things. Like, it's interesting that you mentioned, you know, L1-2. I've noticed recently, and obviously referral bias, but just during COVID times, since March, really, I've seen a lot more thoracolumbar type presenting in, you know, the upper pelvis, upper glute sort of area. It even has a name. It's Main syndrome.
Main syndrome. See a lot of that.
Yeah. Of it.
You know, myself with my scoliosis, I've started for the first time in my life to have, I'm going to share this with everybody, I've actually started to have some urinary leakage, which is, because I couldn't teach yoga for 4 months, because I'd normally teach a few classes a week, 4 or 5. I actually was doing a bit of online stuff, but I was pretty lazy. I was walking my puppy, but I wasn't doing my full yoga stretching. My scoliosis, actually for the first time in my 49 years, bothered me. And it was because I was sitting down, not doing my yoga, doing a lot of prep and things like that for more hours at a time than I had done previously. A lot to do with being on Zoom and not being able to move, like shifting my body weight, that natural thing, because your face is fixed onto the screen for 6 hours. And I'd wake up and I'd go, damn, I'm really stiff in my back and my sacroiliac joint. So I'd go off to the loo and empty my bladder, and then about 3 seconds later, I'd be leaking. And there'd be like this post-void dribble that my patients get, and I'd think, what the hell's that? And then I recalled that I'd had it a couple more times over the PhD intensive thesis writing phases, and it was actually, I recalled, linked up to my SIJ being a bit more locked up because of my scoliosis. And I went and got that x-ray, and I went, wow, where that curve is at 53 degrees, there's compression at L1-2 and L2-3. And so long as I keep my yoga and thoracolumbar spine mobility going, I don't get that urinary leakage. My pelvic floor is pretty good state. So it's actually not that at all. It's the nerve supply to my pelvic floor. And the effects of osteoarthritis as people age and limb length discrepancies and things like that, they're going to have an impact that might not catch up until the 4th, 5th decade plus. So there's a huge musculoskeletal background component here. And that's where, you know, pelvic health physiotherapists shouldn't lose their skills of the whole body assessment, because it's so pivotal. I've heard of a number of physios recently say they don't want to see musk patients in the women's health sector because they specialise in women's health. And I'm like, well, we're going to miss.
What's so Carolyn says, it's musculoskeletal in a cave.
Yes. Yes. I've got a sticker here. Orthopedics in a cave. I've got it on my.
Or maybe it was orthopedics in a cave. You're
I've got a sticker. I've got a sticker on my laptop.
I need to have one of those. And I would direct people to go back and listen to the interview that we did with Carolyn Van Dyken, because that was amazing. And she also talked about, and there was a study, I think, that she talked about, Anthony, which talked about thoracolumbar or upper lumbar screening and treatment for people with OAB, and having, treating the upper lumbar spine, and I don't know, 60-70% of people getting better. Yeah. And
even some of my lingering post-prostatectomy incontinence patients, I just go for the spine. If their pelvic floor looks fantastic and they're actually coping pretty well, I'm working on their spines to fix their post-prostatectomy incontinence.
Mm.
Yeah, fantastic.
Delayed, if it's delayed.
Yes, awesome. Look, we've come to that time because we know that you have a time limit, and otherwise we would talk for hours and get more and more gems from you. Thank you for sharing everything. It's my job to try and summarize everything. So let me try my best.
Before you do, sorry, Anthony, because I have got a couple more minutes. We haven't really mentioned the penis podcast.
I'll get into that.
Oh, sorry. Okay. Great.
I will mention it. I promise.
That's okay. It's only just been released, so it's a little bit tricky to find still. So I just want to explain that.
Make sure that people find it, because we'll have links available for people. So, we started off by talking about some of the things that you were looking at in your PhD and some of the journey and your clinical experiences as to why you headed down the path that you did, and the surprise of the Peyroneus Disease inclusion in your PhD, some of the case study work which led into a randomized controlled trial. I think some of the takeaways there are things like waiting and seeing can actually cause more problems. And your trial showed that there's increase in calcification that's observable if you delay it, even the 4 to 6 weeks of delay. And then, therapeutic ultrasound at relatively high doses was helpful. And you about extracorporeal shockwave therapy. I'm pretty sure that's what you were talking about, and how that's helpful as well in preventing progression of that. You talked about the genetic susceptibility of certain types of genetic predispositions to developing Peyroneus disease, and also the disturbing 1 in 6 people with a radical prostatectomy, 1 in 10 people in general population who have Peyroneus disease. That was pretty shocking as well. That's a lot of numbers of people if we just add up the billions around the world. The lack of awareness about it, the reluctance really about talking about it, both the urologist and the person who's dealing with it. But also the stories of hope, like the boy and his mother, and, being able to be proactive, and how in Australia we're doing really well. And we're exporting this stuff around the world. There's lots of worldwide collaborators we've mentioned throughout the podcast, as well as heart health, being able to use screening questions. We even ended up on Main syndrome, as well as thoracolumbar involvement in pelvic health conditions as well. And we briefly mentioned and touched on the podcast that you have. See, I knew I'd bring it back in.
Oh, thank you. Yeah.
Penis project that you have, and you sent us a link, and we're going to make sure that the link is there. You can find it in Podbean. But do you want to tell us a little bit more about that, and about who you're doing it with, and what it's all about, so that people can find out more about you, about your work, and about how to contact you if they have any questions, because the Women's Health podcast, everybody's health affects everybody else. We got to live with each other. And so the more we know just in general about anything, it's going to help with interpersonal relationships. Oh, and that's the bit that I forgot to say. Yeah. So much of your work is truly biopsychosocial, because if we're just looking at the issues in the tissues, we're missing so many of the complexity and the suffering that's going on, because it's not just the suffering that's occurring through the tissues that's there. So did you want to tell us a bit about the...
Yeah, well, first of all, I love your tissues, the issues in the tissues, actually. I might steal that, but I'll quote you.
It's... or somebody.
It's the everyday bloke. So at the beginning of the PhD, all I actually want to do was have a voice for the guys that had a consistent story that weren't really that comfortable to share their stories and ask intimate questions. I have had the fortune of working with thousands of men, more than 3,500 men going through prostate cancer. So that means I've got a huge body of work from which to draw inspiration and information. Every single patient I learn something else from. I always say I'm here to listen and learn because I'm a female, never ever going to go through what they are. And that was really the reason why the podcast series came about. As we mentioned earlier before we started, I did have a whole year lined up to go traveling with the opportunity to share my PhD findings at numerous international conferences, which were all, of course, COVID closed. But then, you know, because I was a bit quieter in the clinic and I got to work and chat to a little bit more, I guess my appointments were just longer. I did a lot more Zoom, but we didn't have to close down here in Perth. So I kept a trickle of patients coming through, no pun intended. And Melissa Hadley-Barrett and I started working together, and Melissa and I were having more and more chats as she worked in a room up the corridor from our clinic, and I just saw this bubbly person with a little bit of wild curly hair, a bit like myself, just having fun with it, and the guys relating to her. And then we would, if I was seeing her patient, she would refer them, I would refer them to her. Sorry, we were basically realizing that if the patients weren't sorted with their continence, even 10 years after, she would send them to me and vice versa. So we had this good thing going, and then we just realized that our lingo was getting to the soft spot. What Melissa really wanted to do was engage partners more, because she felt that a lot of the burden was being left to men. So she makes a point of having the partners always come to consults. I've always tried to do that as well, but most men are a bit reluctant. However, Melissa makes it comfortable. So Melissa's conversational approach, which if you listen to the Focus podcast that we did the other day on the ABC radio, I've sent a link to you guys for that. She's got a broad background in regional health. She's a nurse practitioner, spent 20 years traveling around the country being the gyno, the local doctor, the GP, the whatever it might require. Plus she does sexology. She's a sexologist. So we're a good team. We ask the personal questions, and we're doing a podcast where we present a man whose story is the forefront of our discussion. So we've got willing participants. They all, we've got more than 75 topics. We're calling it the Penis Project and all things P in men's health. We've got more than 75 topics starting with P to cover. So we thought we might do fortnightly, but we're pretty comfortable with doing it once a week because we've got patients in our rooms already who we're linking up with. The first month is all about Prostate Cancer Awareness Month. So our first podcast was just interviewing another chapter called Phil, who was a younger prostate cancer patient. Next week, this week we'll later release one that's about an older patient that went through a bit more of a tricky time. But the object is, it's about a 45-minute chat telling the story of a real man with his real story of his very personal problems dealing with anything P to do with his private parts. It's anonymous. The guys are coming up with names that start with P, Paul, Pablo, Picasso, if they want to, or some of them have been happy to share their names. So we want to drop out these podcasts once a week, but also I've already pre-recorded about 5 little segments, like how to do pelvic floor exercises if you're a bloke, how to, scan and self-assess. Melissa's going to do a few of those as well. So we're just going to have a few 5-minute, little topics here and there that enable, you to grab on and learn a skill. And I must say, having that blind man the other day was a really helpful thing, because I really just taught him yoga, which was feeling, breathing, being familiar with his body parts, while we taught him a pelvic floor regime. So yeah, the Penis Project podcast and all things P and men's health is just been launched 2 days ago and currently on Podbean, but you have to go through a review process with the Spotify, and as you guys would know, and we're almost at the end of that. So hopefully next week it'll be everywhere.
Fantastic stuff, Jo. We really do wish you all the best. It's been fantastic. We have to get you back to talk about all the other things that we haven't touched on today. It's truly been a pleasure. If anyone wants to get in contact with you, what's the easiest way to find you?
Probably just my my email, which is jo@completephysiotherapy.com.au. Or if they want to know anything about the penis project, just basically Google that, the penis project.org, and that's where you can subscribe. So you simply just leave your email. We don't want anything more than that, and we'll shoot you out the podcasts as we deliver them with Melissa and myself. We've got a landing page website there, so you can get a bit of info that links both to our website. Melissa's got a really awesome website. I really desperately need to update my website.
Hers is fantastic.
It's yeah, we're breaking down the barriers. We're having the conversation, and thank you so much for just continuing it with me.
Thank you so much, Jo. Funnily enough, I know you got to go, but just very quickly, Anthony and I were in a group chat with some colleagues the other day, and someone brought up your name and said, "Oh my God, Jo Milios is amazing," and we just out of the blue, and Anthony and I were just like, "Yeah, she is," because you're so generous with your time. Every time I speak to you, I learn so much, but I know that your passion for helping these men just shines through. And I know that when you were doing your studies, you were just treating patients all like before you came into work, on weekends. So much unpaid work that has gone into all of this. And so just on behalf of everyone, I want to say thank you for everything that you've done. And you've always been so keen just to put the information out there and not hold on to any of it, and just help these blokes. And I really admire you for that. So thank you.
Oh, thank you. And may I just say that one of the reasons I'm so generous is because I got so many doors shut in my face early on. And you just need a little crack in the door, a little bit of light, a little bit of hope. And whatever you do, you can move forward. So thanks, guys.
No,
Thanks,
thank
Jo.
you. And, it's just, I feel like I'm a very small, but much bigger than you. It's a very small opposite, like you're a female physio in a male pelvic health setting, and I'm a male physio in a female pelvic health setting.
Yeah.
So, I know what you mean with the doors in the face thing as well. So it's fantastic to hear from you, and thank you very much for sharing. And I hope all of you like and enjoyed the podcast. If you'd like to hear more from Jo, please let us know. We would love to get Jo back on again to talk about all the things that you would love to hear. And please go check out the Penis Project, as well as contact Jo and, let her know what you liked or didn't like, or any questions that you have. She's a fantastic person and resource. And thank you very much for being on the show, Jo.
I'm just going to say namaste. Thank you.
Thanks.
Namaste.
Namaste.
Well, that's it for this episode. Be sure to hit like if you enjoyed the episode, and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast. Hey everybody, I just thought we'll add the bonus footage from last year where we only had 8 minutes, unfortunately. So enjoy the extras. Hey everybody, welcome back to the podcast. Anthony Lowe here, and I've got Marika with me as usual. How you going, Marika?
I'm very well, thanks, Anthony. And yourself?
Oh yeah, pretty good. Not too bad. Pretty tired, but it's been fun. Just on a camp recently with some young adults, so they run you ragged, I tell you. It's been good. And we've got with us Jo Milios. How are you, Jo?
I'm really well, thanks, Anthony.
Yeah, I'm
Awesome.
going to stop you right there, Anthony, because that's Dr. Jo. That's Dr. Jo Milios, who
My
has
fault.
just received her PhD. Massive congrats to you, Jo. All those years of hard work.
Yeah, but a fascinating experience. It was a good way of utilizing my free time instead of watching The Bachelorette.
Oh God. Yeah, valid point. You might be finding your brain expanding rather than shrinking. Hey, Jo, we've people might be thinking like, you guys run the Women's Health podcast. Why on earth have you got a men's health specialist coming on? But Anthony and I really wanted to get you because this month is Movember, which I'm going to ask you to just explain what it is. But also because many of our listeners have males in their lives, whether that is a partner or a father or a brother. And we think that, you know, what you've been learning about and teaching about and working the area. Woo! I thought that was an alarm at first. That was just an Australian bird.
That's a local magpie.
We think that what you basically, the area that you're working in and the skill set that you're developing in physios around the globe is so important in improving quality of life in men's health. So we wanted to get you for Movember, but for those that don't know, can you explain what Movember is?
Yeah, so Movember is basically an international month of awareness for men's health with a focus on prostate cancer, testicular cancer, and mental health in males. And it's actually started in Melbourne in about 1994 with a couple of guys just having a bit of a drink one day in the local pub and deciding that they'd grow a moustache and bring back the 70s moustache, only to then get a bit of attention for it and think, well, maybe we could do something and do a bit of fundraising. So it's a pretty awesome thing that's now spread globally. And yeah, November, the message is grow a mo to create awareness and a bit of discussion.
Oh, that's awesome. I love seeing the pictures on the internet. Oh, don't worry about the magpie. I love seeing my friends just grow these fabulous, I joke that they're porn star moustaches, but you know what I mean.
Yeah, they are.
So how did you come to work in men's health? Would you mind telling us a little bit about your journey as a physiotherapist?
Yeah, so originally I was a physiotherapist working in musculoskeletal in private practice. And basically I had, you know, really been enjoying my work for quite a long time. So I've decided to visit me. I'm just going to shoo them away. Let's cut 1 second. You guys, go away. How I got into men's health. So basically I was a musculoskeletal physiotherapist for about 15 years and quite enjoying all of that, working part-time in a couple of clinical locations. And then my brother approached me one day and he happened to be recently qualified as a urologist and had spent some time over in the UK. And he'd basically come across the new laparoscopic technique for removing prostate cancer surgery, which was a lot less invasive. And it basically meant that men could have treatment without going through the full open technique. That enabled a lot less side effects for them surgically, and he was really keen to involve a little bit of physiotherapy in his treatment and rehabilitation, and he sort of asked me if I could help, and I was very, very interested and looked into doing some postgrad learning. And at the time, the women's health course in Western Australia was actually not running for a few years, and when I looked into it anyway, there was not very much, if any, men's health components. So I figured I'd better just start following my brother around and watch him do surgery, and started just interviewing patients. And for a couple of years, just learnt from the ground up, really.
Wow. It's I'm just thinking, wow, that's a hard route to take, you know, like because you know the women's health course wasn't running for you, and having to learn from the ground up that way. In what way did you find pelvic floor muscle training the way that you observe that it works, and I don't know how much women's health experience or you've come across. Like, what was some of the key things that you learnt during that time?
Well, basically that, first of all, men were very, very unfamiliar with even having a pelvic floor. A lot of them didn't even know they had a prostate, let alone calling it prostrate instead of prostate. So virtually they came in with nil knowledge. They knew that if they had a diagnosis of prostate cancer, that they were going to
be cured if they succumb to this surgery that was going to leave them incontinent and impotent. So generally they were quite distressed, and I found that that psychological impact on men was massive. So I realized that I needed to really simplify the understanding of male anatomy for most of those patients, learn a whole new language really that would make men feel comfortable, and to not sort of over-medicalise things. Also that they were very, very distressed about having internal examinations. So the traditional pathway for pelvic floor muscle assessment was the digital rectal examination at the time. I had quite a lot of discussion with my brother over this actually, and he agreed that potentially it might be better for us to look into ultrasound approach for pelvic floor muscle testing. And I was very keen to do that myself and leave him to do a lot of the internal testing for the prostatic component of diagnosis. And just having men have several internal examinations was quite clearly not something they were typically comfortable with. So we're fortunate to have Dr. Judith Thompson here in Western Australia. So I actually contacted her around 2005, 2006, and she gave me quite a bit of mentoring and teaching in the ultrasound approaches. At the time, she was actually doing her own PhD in ultrasound approaches of pelvic floor muscle testing in women. So it was really helpful to have her guide me. And then I just spent a lot of time searching on the internet and linking with whoever else was doing it on women, because not a lot in men, and came across a few people in different patches of the world. But yeah, overall it was just starting right from the basics.
So you found your tribe, Jo, and that tribe is growing. It's growing.
Tribe is growing, but men are really not that great at asking for assistance, and that's the thing I found, that they were actually opening up to me. I think back to your question, Anthony, about whether or not I had much women's health experience. I had a few colleagues that I was working with that I'd refer my female patients to if they came across anything that was a little bit more advanced and out of my scope of experience. But generally, I found that men were very open talking to me. And many times they've said comments like, "Oh, I'm so relieved that you're a female because you know what it's like to have problems down there. You know what it's like to have pads or be wearing, sanitary products."